Good morning and greetings from Max Institute of Cancer Care. I am Dr. Akshay Tiwari, the Director of Musculoskeletal Oncology. And the topic for today's discussion is biopsy for bone tumors. We all know the importance of biopsy in the management of both benign and malignant bone tumors. And it was back in 1958 that Jaffe said that the biopsy should be regarded as the final diagnostic procedure and not a shortcut to diagnosis, which means we have to have our diagnostic workup completed before we contemplate biopsy. We are never tired of quoting these two papers from Mankin, where in 1982, he tried to look at 329 patients who underwent biopsy for bone and soft tissue sarcomas. The major errors in diagnosis was 18.2% if the patient underwent a biopsy at a referring center. Not just that, an unnecessary amputation was to be resorted to in about 4.5% of these patients just because of a badly done biopsy. Ironically, he revisited the same question again in 1996, where he could see that the changes in course, the errors and complications were 2 to 12 times higher when the biopsy was done in a referring institution instead of in a treatment center, which shows the importance of biopsy being done only and only at a high volume center where sarcoma surgeries are routinely done. So before you think of biopsy being just a small procedure which can be done quickly, just beware of the danger that might be lurking behind. So let us look at what we need to do when we discuss biopsy or when we think of doing a biopsy. The first do is to suspect. Unless we suspect, how are you going to think of doing a biopsy? Which means that we have to keep the index of our suspicion low for a bone tumor. We all know that bone tumor is not a very common entity. In fact, even in a busy general orthopedic practice, you're not going to see one or two, not more than one or two bone sarcomas in a year, probably. So to keep your suspicion low is very important, and you suspect a bone tumor, only then you go ahead and do a biopsy. So what are the warning signs? Any lesion in an extremity, any mass or lump, which is more than 5 centimeters deep fascia, is increasing in size over time, either clinically or on radiology, or is painful, has to be treated and should be considered to be malignant unless proven otherwise. The next do is to ask a history of previous malignancy, the mode of onset, progression, and a family history of similar lesions are some of the many questions that you need to ask before you perform a biopsy, just to be sure what you are dealing with. For example, this patient had a mid-diaphyseal osteoblastic lesion over the diaphysis of the humerus, and as we can see, the histopathology came out to be an osteosarcoma. But all we needed to know was that the onset of pain in the arm came only after a few sessions of bodybuilding exercises. There was a tender swelling over the arm, and the swelling was gradually hardening with reduction in pain with time. All this clearly indicated towards it being a myositis and not an osteosarcoma. Of course, the pathologist needs to know the history before he can differentiate between myositis and osteosarcoma. All we needed to do was to follow up this patient, and we could see the resolution happening both on X-rays and on MRIs. The next do is to consult. A radiologist, a pathologist, a medical oncologist, radiation oncologist, and your friendly neighborhood orthopedic oncologist might come in handy when you are thinking about performing a biopsy. Just be sure you know all you need to know before you go ahead and do a biopsy. The rules of imaging need to be followed. All imaging comes before biopsy. The whole bone needs to be imaged, and the staging workup should be done preferably before a biopsy. One thing that we really need to ask ourselves is that, is biopsy really required? A lesion like this, which is incidentally picked up, which is painless and was picked up only on an X-ray done for something else, probably needs to be left alone. This clearly is a non-ossifying fibroma in the metaphysis of an adolescent, where the X-ray was done for an injury. So not all lesions need to be biopsied, and we need to be careful about this. The next do, and a very important do, is to refer. If a malignancy is suspected, refer the patient to a specialized center before your biopsy and not after doing your biopsy. What kind of biopsy do you prefer to do? In an orthopedic oncologist practice, more than 90% of patients will be diagnosed on a core biopsy under local anesthesia on an OPD basis. However, some patients may require an excision biopsy. For example, some obviously benign lesions, which can be excised straight away, or a small bony or soft tissue mass that you can excise with wide margins without much functional or anatomical loss. An open biopsy, also called an incisional biopsy, is again popular among a lot of people. There's nothing wrong in doing it, but we have to be careful when we perform an open biopsy in following the principles of the biopsy that we are going to discuss in subsequent slides. Generally, in my practice and most orthopedic oncology practice, a precious biopsy, example, a biopsy in a small child where general anesthesia is being given, or where some large amount of material is required for some ancillary studies, or where a core biopsy has failed after a couple of times. This is where we usually resort to an incisional biopsy. An FNAC also is popular among a lot of orthopedic surgeons, just for the simple fact that it's painless. It can be done in an OPD, requires no anesthesia. But generally speaking, FNAC should be regarded as unreliable for a primary diagnosis. The only instance where we rely on an FNAC is when we are trying to prove a recurrence in a known case of a malignancy. Let us look at a case in point. This proximal metaphyseal lesion was subjected to an FNAC, and the FNAC showed a giant cell-rich lesion. The unsuspecting orthopedician went on to curate it and cement it, thinking it to be a giant cell tumor. But lo and behold, it comes out to be an osteosarcoma, which is giant cell rich. So it's always better to do a core biopsy or an open biopsy and not rely on FNAC for primary diagnosis. Another important thing is to use image guidance wherever required. For example, locations like the spine, pelvis, and others, even sacrum or sometimes the scapula, where you may not be able to access the lesion, which is deep, you may want to use either image guidance, either it could be a C-arm or a CT scan guidance. Soft tissue lesions sometimes require ultrasound guidance for true-cut biopsy. A PET-guided biopsy is one where you use the FDG avidity as a guide to increase the chances of a good yield of your biopsy. And you target the more PET-avid area in your CT-guided biopsy. One important principle that we must remember is that the biopsy incision should be in line with the planned incision of final limb salvage surgery, which is why it is important and desirable that the surgeon who is going to perform the final limb salvage surgery performs the biopsy himself. So if we look at the important areas where bone tumors are found, we can see that for a proximal femur, a lateral or a medial approach, depending on the presence of soft tissue component. And similarly, for the distal femur, you could have either a medial or a lateral approach to your biopsy. As far as the tibia goes, again, you can have a biopsy tract either through the anterolateral compartment or the medial subcutaneous bone, depending on where you have your soft tissue component. For the proximal humerus, it is very important that we keep the biopsy tract not through the deltopectoral groove, which might lead to contamination of the whole groove, but through the anterior half of the deltoid muscle. So let us look at an example where the soft tissue component is lying posterior to the distal femur. What are you going to avoid? Of course, you would want to avoid the neurovascular bundle because you don't want to injure it and you don't want to contaminate that area. Again, the joint space needs to be avoided because you don't want contamination of the joint space either. Similarly, uninvolved bone is something that you would want to avoid because then you can spare that bone in your final resection. You should also avoid traversing multiple muscle compartments so that you have to excise just one muscle compartment, and the and the biopsy hematoma does not violate more than one muscle compartment. So in this case, you would want to go either medial or lateral, keeping your track a little posterior so that you contaminate a single muscle compartment, leave the joint and the neurovascular bundle, and target the soft tissue component of the biopsy of the tumor. Again, some principles of biopsy. We must avoid raising flaps when we're doing an open biopsy. The approach should be sharp and direct so that we do not end up contaminating various planes as we retract separate layers. We should try and breach a single compartment, again, to avoid a large hematoma involving multiple muscles. Another important thing to remember is that we must avoid necrotic or cystic areas which are less likely to yield tissue for diagnosis, which is why it is so important to perform your imaging before you do your biopsy and not afterwards. We have to remember certain mimics. For example, an osteoporosis may actually be a myeloma, a giant cell tumor could be a giant cell rich osteosarcoma, so on and so forth. And we must remember all these when we are performing a biopsy. So having discussed what to do, let us discuss what not to do when performing a biopsy. Don't presume is the first don't that I always keep in mind. We cannot presume something to be a particular thing just because we can see it on radiology. We must prove it by biopsy before going ahead with final treatment. And a couple of cases in point will show you how. A sacral mass as large as this was being treated with antitubercular treatment for 9 months before the patient presented to us. A small biopsy was all that was required to show that it was a giant cell tumor. But by the time she came to us, it was already unresectable. Similarly, a so-called pot spine of the dorsal vertebra was treated on ATT for 2 months with worsening of neurological symptoms. A CT-guided biopsy showed it to be an osteoblastoma. What he needed was not ATT, but a vertebrectomy and fixation. The patient is now doing fine, even 7 or 8 years after his primary surgery. Again, a 35-year-old lady with left hip pain was treated with antitubercular treatment for 3 months, but it was actually found to be a pigmented villonodular synovitis on MRI and biopsy. Another don't is to not mix biopsy with fixation, and I'll show you why. It may actually turn out to be unnecessary, may lead to dissemination of disease, and it may actually complicate or sometimes contraindicate limb salvage. Because when you are biopsying it and you don't know whether it's a sarcoma that will need wide resection, you may end up contaminating the whole medullary canal, thereby increasing the extent of bone that you have to excise. Again, for a similar reason, do not curate and fill unless you have a biopsy proof. This patient had a distal metaphyseal femoral lesion, was treated with curettage, biopsy, and at the same time, a fixation. So all the principles of biopsy were violated, and the histopathology comes out to be osteosarcoma. So what could have been an easy limb salvage surgery for this child? It actually came out to be a hip disarticulation, just because there was widespread contamination, not just of the soft tissues around, but also of the whole femur bone. Again, don't biopsy if you're not sure. Just ask yourself if you are the right person to biopsy, or you should refer this to someone else. An improperly performed biopsy in a pelvic osteosarcoma leads to a hindquarter amputation, just because the whole gluteal flap was contaminated. Whereas a very similar case, but with a properly performed biopsy, could undergo a limb salvage surgery, a similar osteosarcoma of the iliac bone. He could undergo limb salvage surgery and he remains cured of disease more than 10 years after his primary surgery. So such is the impact a good or a bad biopsy can have in the patient's outcome. Other things that we must remember to avoid is to avoid drains if possible. And if at all you have to keep it in line with the incision and distal to it and not far away from it. Remember, a final limb salvage surgery will have to include not just your incision, but also your drain sites. Another thing that we must avoid, which has been a practice with some, is to avoid sending tissue into labs. Sarcomas are heterogeneous and you may end up having two different opinions from two different labs. The best way, if you want to have a second opinion, is to send the whole tissue to a single good lab with musculoskeletal pathology experience preferably. But in case you want to have a second opinion, get blocks issued from the lab after they have seen the whole tissue and then send it to the next lab. Again, avoid traversing multiple planes or compartments when you are doing a biopsy for a sarcoma. Avoid transverse incisions or incisions which are not in line with the final limb salvage surgery incision. For the same reason, avoid multiple scars. If you have failed biopsy, don't keep adding another scar just because you could not get a result in the previous biopsy. You must also avoid a hematoma or a widespread contamination, and to repeat the previous steps, avoid raising flaps, sharp and direct approach, breach a single muscle compartment, good hemostasis, and using a bone wax or cement may not be out of place if at all you have to make a window in the bone. Avoid a drain, or a drain, if at all it's to be placed, should be distal and in line with your biopsy incision. The suture placement should be close to the scar. Remember, all the skin that involves the sutures needs to be excised, and wide suture marks make it difficult to have a good soft tissue closure, and the patient may end up having a flap or some plastic surgery for that closure. To avoid a post-biopsy fracture, use soft tissue component for biopsy if possible. If a sarcoma of a bone has a soft tissue component, we don't actually need to enter the bone and weaken it anymore. If at all we have to make a window in the bone for biopsy, in the absence of soft tissue, use an ovoid or circular window if at all required. So if you get a skeletal lesion, you start thinking that you can cure it and bone graft it, or you start thinking what on earth it could be, or you think about biopsying and at the same time fixing that, or you sometimes think about starting antitubercular treatment and see the response after a month. Now we can see, after having gone through this presentation, that only the second approach is the correct one. You start thinking what it is, investigate further, go back to your clinical biochemistry and radiology inputs, and then see whether you need to biopsy it or something else. Remember where we started, the sequence always remains careful clinical evaluation, analysis of the imaging studies, and then biopsy. It cannot jump from step 1 directly to step 3. The diagnosis of a musculoskeletal lesion is a jigsaw that involves clinical, radiological, and histopathological inputs. If the jigsaw doesn't fit, you must question the diagnosis again. To conclude, keep a high index of suspicion for bone tumors, refer early if malignancy is suspected, and biopsy only if you are sure you should be doing it. Again, avoid treatment on presumptive diagnosis and keep the principles of biopsy in mind when you are doing it. Thanks a lot. Thank you.